It is now my privilege to introduce our faculty, Jordan B. Strom, MD, MSc, FACC, FASE, Medical Director, Echocardiography Laboratory, Division of Cardiovascular Medicine, Beth Israel Deaconess Medical Center, Assistant Professor of Medicine, Harvard Medical School, Boston, Massachusetts, and our second faculty member, Jessica Stout, BS, RDCS, FASE, Technical Director, Echocardiography Laboratory, Beth Israel Deaconess Medical Center, Boston, Massachusetts. Let's start out. Dr. Strom.
Thank you very much, and thank you for joining us today. It is really my pleasure and privilege to present to you today on how to operate a safe and efficient cardiac CEUS laboratory. I think we have a lot of good content in store for you. We will be presenting on behalf of the International Contrast Ultrasound Society, and so this is a free webinar provided by ICUS in coordination with Northwest Imaging Firms, our CME provider, and wanted to introduce you to ICUS as well, if you haven't otherwise been familiar. So ICUS is the International Contrast Ultrasound Society. It is a vendor-neutral forum for discussing contrast and promoting use of ultrasound contrast across radiology, cardiology, and many other fields. It's a global professional society focused solely on CEUS, with members in 60 countries, as well as physicians, sonographers, nurses, scientists, industry members, as well as patients and otherwise. So it is really a great society. It's free to join. Here's a QR code. There's never a fee for anything, so feel free to use this QR code, sign up for ICUS. There are free webinars just like this that offer CME credits. In addition, there's a wonderful website, the ICUS website that has, as well as a mobile app, ICUS Connect app, that has webinars. They have cases of the day, sonographer training hubs, a lot of content in terms of materials, protocols and suggestions, literature out there, Bubble TV, Bubble blogs, and more. And all of this is really translated into multiple different languages, including Mandarin and other translations available. So encourage you to become members as well as to check out the really great content. And so we have free live webinars throughout the course of the year, and really want to show contrast as a safe, portable, radiation-free method to be able to really get a lot of information about our patients, and important to make diagnoses long-term. There's a case of the day, as I mentioned, that can help build in confidence with experts in the field going through and having quiz and dynamic images and teaching points. And there are a number of different resources for sonographer training, starting from basic introduction to contrast, to all the way through to a lot more content and advanced applications. And then the ICUS Connect website app is here. These are the QR codes. If you have an Apple iPhone or an Android, it's a great download. Lots of material right at your fingertips, and all the information, basically all the information that is on the website, is also available in the app. And then we do have a news monitor. We have a news blast that ultimately communicates bubble news and trends across multiple different modalities. Like I said, the website is a ton of information. We also are on social media. These are our social media links, so please follow us on social media, join in the conversation. We encourage you to join us along this journey. So thank you to our sponsors for having us. We will be talking today about how and why to implement CEUS safely in your lab. I'll then be passing the baton to Jessica to be talking about managing a safe and efficient CEUS laboratory, and talking about the Beth Israel Deaconess Medical Center's experience in doing so. And then we'll end up with cases from the Beth Israel Deaconess Medical Center using contrast, followed by questions and answers. And I would encourage at any point along the journey here, if anybody has any questions, please do use the Q&A box. Those questions will continue to file in, and we see them. We'll answer them as they come up when we have the time period at the conclusion of the program. So thank you very much, and we'll start with the program now. Let me see if I can share my screen. Excellent. All right. So again, it's my privilege to discuss with you today how and why to implement CEUS safely in your laboratory. And these are my disclosures. One disclosure that's worth mentioning is we will be talking about uses for CEUS other than the FDA-approved indication for left ventricular opacification. We sometimes will interchangeably use the word contrast in ultrasound enhancing agents. We do prefer the word UEA or ultrasound enhancing agents with our patients to distinguish it from iodinated contrast. Many patients may be fearful about contrast to thinking that it's synonymous with iodinated contrast. Maybe they had a bad reaction to iodinated contrast in the past, or know about the risks of kidney failure with it. So I think it's important to be able to use that. But in general, the term contrast in this setting means ultrasound contrast, and it's very different than ultrasound than iodinated contrast or other types of contrast like gadolinium. We will be talking about other indications other than this left ventricular opacification. There are a number of uses, including perfusion, as well as therapeutic uses that are already developed or are in the pipeline, and we will be talking about those as well. So I'm going to start off with first the why. Why do we want to use contrast ultrasound? And I think we can summarize the literature in a couple of slides here. But in general, there's enormous wealth of material and information that contrast helps with or adds to your study. So, for example, we know that ejection fractions are more reliable. That is, the inter-observer variability between different people reading an echocardiogram and determining their ejection fraction is reduced when using contrast, similar to that of a cardiac MRI, which we know is the gold standard. Similarly, when looking at regional wall motion assessment, it improves the inter-observer agreement compared to unenhanced imaging, and it improves the confidence, sensitivity, and specificity of stress interpretation in the setting of technically difficult images. It has a great use in looking at and defining intracardiac masses, particularly that initial inflow of contrast into a given structure can help tell you whether or not that structure is vascular or avascular. So it's a really, really helpful tool that's used here. And seminal work by Sharon Movey and others really sort of looked at apical abnormalities. And in fact, contrast helps to identify the presence of apical hypertrophic cardiomyopathy and the presence of an aneurysm in hypertrophic cardiomyopathy. We know that aneurysms in apical HCM are associated with an increased risk of not only arrhythmia, but also thromboembolism. So this is important in terms of risk stratifying patients. It can also be used to help define other apical abnormalities like thrombus that may be at the apex in unclear cases. When used in transesophageal echocardiography, it can help improve the confidence for thrombus exclusion prior to cardioversion, and at least in one small study, may actually be associated with a reduction in the risk of thromboembolic events after cardioversion. Left ventricular opacification, it can be used for left ventricular opacification in the setting of stress, and in that setting, improves accuracy, reproducibility, and reader confidence with over 99% of individuals having diagnostic images, and has been associated in that context with lower downstream testing and cost, in part due to the making the diagnosis upfront. Contrast can be used for perfusion. We don't delve as much into this on this particular talk, but the contrast bubbles are like little red blood cells, and so they perform and have a behavior that's similar to red blood cells, and we can take advantage of that to look at the inflow of contrast into the myocardium, as well as the peak uptake, to really understand is a given segment being perfused adequately. And so with inotropic stress, that is with dobutamine, it can help improve coronary artery disease detection versus wall motion analysis alone, define the extent of wall motion abnormalities, and may, in fact, improve upon wall motion analysis in identifying patients at risk for death and myocardial infarction. In Europe, it's very common for people to use high-dose vasodilator, high-dose adenosine for echocardiography and use contrast for perfusion imaging. And in that case, it has equivalent specificity or higher sensitivity than SPECT, the next gold standard. It enhanced prognostic value for SPECT, And in those really difficult cases of those patients with left bundle branch block and non-ischemic wall motion abnormalities, it actually helps improve the detection of ischemia versus SPECT alone. We can not only look at this qualitatively and say there's an area and segment that's not getting as much blood flow based on its appearance, but we can also put a region of interest over that given area and measure quantitatively how much uptake of contrast there is. And so quantitative stress imaging has been advocated, and this has a sensitivity and specificity of greater than 80% versus the gold standard of angiography. And it also provides superior prognostic information versus qualitative analysis alone. So I've just said there's a number of different uses of this. Let's talk about how it actually is used in practice. So in general, contrast is way underutilized relative to need. And I will frame this discussion by if we were to go into a radiology lab, and people would not look twice at getting contrast for a CTA or an MRI. But we are in a different situation here in ultrasound in that there seems to be a reticence to be able to use it despite all the benefits that I've shown. And so let me show you some data to back that up. So this is from our own institutional experience, over 172,000 transthoracic echoes, over about 10,000 patients over 18 years. And here you can see in the red is the probability of having suboptimal image quality over time. And the blue is the rate of, or the probability of receiving contrast. And so what you can see here on the y-axis is the probability, on the x-axis is as the year. And so if you just looked at contrast use alone, and here in the blue, you'd say we're doing a great job. We're using more and more contrast as the years went by. The challenge with this is that this only tells you one part of the equation. If we look at suboptimal image quality, you can find that our rates of suboptimal image quality actually increased greater than the rates of contrast during that same time period. And so while it looks superficially like we're doing well by increasing our contrast use, in fact, actually, we weren't keeping up with the need, the potential need for contrast in this population. And when we look at this overall, only about 2.6% of transthoracic echoes receive contrast, more so amongst inpatients than outpatients. Well, why is that? Inpatients have IVs already. So it makes it easy to give the contrast and to use it. And of course, inpatients also have higher acuity. So this was sort of eye-opening for us in general. In this study, 17% of echoes were suboptimal image quality. We know that on average, 10 to 20% of the population had suboptimal image quality. That's no fault of your own. It's not a sonographer not getting appropriate images. It's just that what the patient comes in with. And ultimately, this is, while we use contrast more in suboptimal quality studies, we still had a big gap to overcome. And so Steve Feinstein, who many of you may know, has been integrally involved with the ICUS. I looked at the slide and told me, Jordy, you really should be updating this because we did do a big push after this study was released to change policy and practice within Beth Israel. And this is something that Jessica will speak to as well. But now you can see that the rates of suboptimal image quality are really, the rate of contrast use have really caught up with that of suboptimal image quality. Why are we seeing increased suboptimal image quality? We looked at this as well. The mean weight for our patients went up dramatically during the time period that we studied. We are using echo in a broader population as a result of increased indications, portability of echoes. We're using echoes in a much broader, sicker population. And that means that the rates of suboptimal image quality that we're encountering are likely increasing. So we want to match them. And so you might say, well, that's just the BI. What about other institutions around the country? So we did a recent study looking at 11 million adults receiving transthoracic echo and about 740,000 receiving stress echo across 2,400 sites in the US. This population database captures about 90% of all hospital discharges and hospital claims in the country. So it's really a sort of a robust look at this. And what we found was that overall, contrast was only used in about 6.8% of outpatient transthoracic studies and about 21% of stress echocardiograms. And I'll put that a little more sort of finely here. So on the left, what you can see is transthoracics. On the right, in the graphic, you can see is stress echocardiograms. On the top, is the use of transthoracic echoes on the left or the use of stress echoes on the right. The darker the color, the more they're using. So for example, New York and Texas and Florida are using a lot of transthoracic echoes. On the bottom, colored in the red, is the proportion of those transthoracics or the portion of those stress echoes in which contrast was used. So here you can see that, for example, while Texas is using a lot of transthoracic echoes, across the board, overall, their rates of utilization for contrast are way lower, for example, than a state like Minnesota or a state like Maine. So there's a huge variability across the country in how much we use this. And taking this a step further, you can see by state here, Minnesota really is at the top of the list. So those of you in Minnesota, kudos to you. I'm going to congratulate you. This is great. Using 20% of all your studies get contrast versus 1.1% of those in Delaware. And I know the comment to this is, well, they're not the same patients. Maybe the patients in Minnesota are different than the patients in Delaware. So we looked at that and we adjusted for not only patient characteristics, all the patient characteristics we could look at, but also site characteristics. And sites that were using contrast happen to be more frequently large, rural sites, nonprofits, and teaching facilities. But even when you adjust for everything under the sun, including a cardiologist's years of experience, their training, we still found a 4.4-fold difference in use of contrast by site. And so really what that speaks to is the need for better standardization of use across the country. We can't have dual standards of care where somebody's walking into one echo lab, one place, in another place, and getting a different standard of care. And so this really speaks to the need to broadly adopt contrast as a whole. So what about outcomes? So we looked at that at least in a smaller population. So we looked at the 90,000 individuals within the same data set who were hospitalized for acute MI. And those who received echoes within 60 days of discharge, about 8% of those received contrast. We found that contrast was associated with a lower rate of coronary angiograms, numerically lower rate of coronary angiograms, and a lower rate, even adjusted for comorbidities, of non-stress imaging. There was no difference in rates of readmission, days alive at home, or cost, although numerically the cost, the total costs of care were about $1,000 cheaper in the group that received the contrast. And so we see this as a sort of good indication that certainly there's not a massive excess risk, but ultimately there seems to be some benefits associated with receiving contrast. So why aren't we using contrast? And so I'll call your attention to this survey. ASE, the American Society of Echocardiography, produces a survey every year that's sent out to not just ASE members, but the sort of the echo community writ large, asking them about a variety of different things related to the field. And it's a great way to sort of capture trends within the field. And so in 2021, they asked the question, please rate the degree to which you find the following tasks difficult. And so there are a number of different tasks, and on the list is things like expanded protocols, longer studies, portable exams, schedules, all those are relevant. But the top thing that people focused on as the most challenging thing was technically difficult patients due to body habits. And this is even more the case now, as I mentioned, as we're expanding our use of echo in different populations. People have seen a number of different challenges with this. So following that up, in your opinion, what are the main barriers preventing your lab or institution from using ultrasound enhancing agents for left ventricular pacification more often? And you could add a bunch of things on the list, but the top two things were it's too much effort. It's too much effort to administer, and sonographers aren't trained or are not in favor due to workflow efficiencies. So the workflow and efficiency barriers are real, and they're really a challenge. And we'll talk about some strategies to be able to deal with them. Following that, of the list of options, what do you believe would be the top driver to increase your appropriate use of ultrasound enhancing agents for left ventricular pacification in your lab or institution? Topping the list there were the ability for sonographers to insert IVs and the ability for sonographers to inject contrast. And I'll talk about that in the next slide a bit further. And when you ask where are the two areas that are the most underutilized, where UEAs are most underutilized, really the top of the list is the hospital outpatient setting. And why is that? Well, patients don't come to us with IVs. And so you have to place an IV, and I certainly can can tell you at our institution, if we wait 45 minutes, you call for an IV, you look at the images, you say, oh, this is suboptimal image quality, I'm going to need contrast. A call for an IV nurse, place an IV. Sometimes that process can take up to 30, 45 minutes. If you have an hour-long study, then that really is prohibitive in terms of your use of contrast. So we'll talk about ways to get around that, but I think that's been a major barrier for individuals in the past. And these barriers start early. So Sharon Mulvey and others within ICUS conducted a survey, which they sent out to 227 program directors for sonographer schools around the country. What they found was that only 18% of schools offer any form of IV insertion, and only 5% offer any kind of certification to individuals on IV training. And when you ask them why do you not have contrast in your curriculum? What are the major barriers? The top response was that the current educators don't have sufficient expertise, and that there's also lack of teaching resources. So lack of teaching resources, we've got you covered. ICUS has you covered. We have a website, we have an app, a lot of information on there. There's also the AAC guidelines, which are tremendous and have lots of information on them. But lack of sufficient expertise is a very big issue. And so if we have educators that aren't trained on this, they're not going to be able to train students, and those students won't become able to become educators and then train the next generation of students. So we're hoping to break this in the cycle, and we have an active program within ICUS and a number of different sonographers involved in this to work with the ARDMS to try to create a system for certification for sonographers, so that if you leave training without IV certification, then you can take a didactic test through this training program, as well as participate in a more of a practicum. And those two skill sets, if you pass those, you'll be granted a certification, a national certification on IV use. Now, whether or not you can place IVs is ultimately up to your institution, but we hope that this will allow you the means to be able to then take a paper to your institution and say, look, I've been trained on IVs. This is a national certification. Can you let me do this? Because it's really important, I think, that we build a strong cadre of sonographers who are skilled in this area. And overall, there are 4 overriding practices that heavily influence contrast use. One is the presence of a standing order for contrast administration. And we have this at Bethesda. So when we order an echocardiogram, it's ordered as an echo with or without contrast, so that the sonographer doesn't have to ask a physician later on for an order and wait for them to put the order in before the contrast is delivered. The second is sonographers enabled to make the decision and administer contrast at the point of care. And this was a big program within our institution, and Jess will talk a little bit more about the process of this. But ultimately, we went through a 2-year process where we worked with the administration to create standards and credentials for sonographers on training. We train them on an annual basis, re-credential people on an annual basis, and we make sure that they pass a didactic portion, a test that essentially says, you know what you're doing, you know how to do this, and you know the safe practices, but also we observe them administering this. And so we've pushed that through the administration. We were able to do this using the precedent that ophthalmologic techs within our institution were giving timolol eye drops under supervision. And so using that as a precedent, we said, well, we can build on that. And we've had a very successful program since that time. Sonographers trained and enabled to place IVs. Again, this is something that is within the ASE scope of practice. It's within the SCMS's scope of practice for sonographers. It's advocated by the International Contrast Ultrasound Society. I can tell you that the next iteration of the SCMS scope of practice will have even a stronger role for sonographers to place IVs. And we hope that the training will come as well with some of these initiatives that we're putting in place. But in addition, we've locally, for example, have brought our sonographers to the cath lab to have them place IVs and practice. We bought a phantom arm to practice on. They're very cheap. You can get them on Amazon. It's very easy to get, and it's a great way to at least practice and get some experience before trying this on human beings. And then having a presence of the physician sonographer advocate. And I think one thing that you can see from just the fact that Jess and I are giving the presentation together is that it really works well, particularly when you have both. When you have a real strong physician and sonographer advocate, both pushing for the same use of contrast within the institution, I think that really sends a message both to the sonographers as well as to the physician staff within the organization to really advocate on contrast use. So in terms of actually reducing workflow barriers, there's really 2 points of decision. So there's the decision time, that is the time it takes to make the decision to give contrast. And then there's the administration time, that's the time it takes to actually administer the contrast. And one thing that we do at Beth Israel is start with the apical views. At our laboratory, we start with an apical 3D triplane. What that allows us to do is to see all the cardinal walls. We're able to assess wall motion. We're able to have a gross assessment of ejection fraction. We also are able to do global longitudinal strain within a single heartbeat. But the other reason we do this and do this up front is that the greatest improvement for contrast enhancement is really with the apical views. So it's really the apical views are best for assessing image quality. So if you start with the apical views, then you know up front, I'm going to need to use contrast for this study or not. And so that's where we can find this helpful. And why do we start traditionally in the exam with a peristernal long axis view? There's no real reason for it. It's historical. It's based on the fact that M mode was historically used for measurements. And so we're not in this era of M mode anymore. I think we can revisit this potentially. And this is one way we've done that. And then the other is to use the decisioning, which I'll speak about. How do we reduce the time for administration? Well, have the contrast locally. Have it on your cart. We keep our, at Beth Israel, we keep the actual contrast vials on our cart. And we go to the patient's bedside and we give the contrast right there. Enabling the sonographers to administer versus via standing order. People don't have to wait around. And then, of course, the use of the decision aid, which I'll talk about now. So within the context of that study, we looked at underutilization. We tried to create a workflow solution for people. So we took the 172,000 transthoracic echoes and we really split it into a derivation and validation sample. And we said, what information is available to people before the images are even acquired that we could use to be able to predict the potential need for contrast? And we didn't want just to predict for receipt of contrast, our 2.6% utilization at the time. We wanted to predict the receipt of contrast, but also the potential need for it and not having receipt. So either suboptimal image quality or the receipt of contrast. And what we found was that there were 3 variables that really rose to the top as being the most important. I think weight makes a lot of sense for everybody. Adipose tissue, team C gets in the way of ultrasound interference. That acoustic attenuation really makes it challenging to see things. More so than BMI, BSA, other measures, weight seem to be of most relevance. Age, and then heart rate we think is more of a proxy for acuity, patient acuity, but in general, they seem to be all very predictive. And so, for example, you could have a medical assistant compute this score for everybody who's coming in for the outcome for a week, and have them have this done. And then you could tell the people who are at high probability of needing contrast to arrive early in the lab so that they have a chance to get an IV placed before they end up having their image acquisition started. And that way, you're making the decision to give contrast based on the images themselves, not based on a workflow barrier or presence or absence of an IV in that setting. So we really feel strongly about this. We ultimately took this algorithm and applied it and validated it at Mid-America Heart Institute, where they used echo contrast in about 23% of their echoes, really quite a robust volume there. The score performed similarly to the Chastity-VASC score to predict contrast use alone. They didn't have information on suboptimal image quality, so we put contrast use alone in here, but it worked pretty well. And so now sonographers at BIDMC are credentialed to administer contrast. We've since created this ICUS Connect app, which I encourage you all to download. There's an online calculator available. It's available on the app. It's also available at this website right here. And it will take you to this page right here, which is the CEUS calculator. And all you have to do is input somebody's weight in kilograms, their age in years, and their heart rate. And it will pop up with a probability that somebody may need contrast. And what we say is that the probability is greater than 15%, then that's the inflection point. That's when you really should be considering the use of an IV to support contrast, with the final decision to give contrast ultimately based on the review of the images. We're studying this prospectively, and we hope that this will ultimately make a big difference in care. But it only makes a difference if people use it. So feel free to download this, use this, and I think will hopefully be helpful going forward. So this is a safety talk. So I wanted to talk about contrast and the safety related to contrast. Now, while contrast, and I'll show you, is amongst the safest of all contrast media, allergic reactions do occur. They occur, so-called anaphylactoid reactions occur in about 1 in 15,000 cases. So they're rare, but they do happen. And particularly if you use enough contrast, you will see this, and you have to be, as a laboratory, prepared for it. The mechanism is thought to be a complement activation related pseudoallergy or a CARPA reaction, which is, that's a very long name, so that's why we call it CARPA. But in general, it's not the typical type 1 hypersensitivity reaction. And so what this means is that you don't have to have had a prior exposure to contrast in order to have this reaction. It could be your first time receiving contrast, and you can have this reaction. And in general, most of these present immediately, but most present certainly within 30 minutes of use. This present as skin, erythema or flushing, urticaria like hives, rash, shortness of breath, throat tightness, flushing, trouble swallowing, abdominal pain or shock in most severe cases. And the IEC has a policy that all echo labs really have to have a policy on early identification and rapid response for severe reactions. And all personnel in your lab should be trained on that. So that doesn't matter if you're a nurse, if you're an exercise physiologist, whoever is working in the lab, they should know that if you walk up to them in the hallway and say, what's our policy on severe reactions? They should know what that is and where to find out that information, if not. So really important for people to have that. And then also important for people to have allergy kits available and accessible. This is an image from our allergy tackle box kit. And this is different than the code card. What most people may not recognize is that there are very different medications and things that are in the code card that are in our allergy kit. So for example, epinephrine, which is the sort of cornerstone of treatment for anaphylaxis or anaphylactoid reactions, in the code card, epinephrine comes at a concentration of 1 in 1,000. An EpiPen comes at a concentration of 1 in 10,000. So it's a completely different medication, and we really encourage people to invest in having allergy kits in some of the areas where they're using this more frequently. So we have an EpiPen. We teach people how to use it. We have things like the saline bag and high pressure system, an IV start kit, famotidine, those kinds of medication as well. So all of this is there. We're happy to share the contents of this. I really think it's a really useful thing to have. Also good to go review with people how to use an EpiPen. Most people may not realize that you have to hold the EpiPen down into the site for a couple of seconds. It takes a couple seconds for the auto injector to work, and so it's not just as you see in the movies, in and out. This is, you want to hold it against the muscle itself if you ever have to use it. There is a low incidence of temporary back pain that's related to retention of microbubbles, or thought to be related to the retention of microbubbles in the glomerular capillaries. And for these reasons, as well as potentially for safety reasons, dilution of these agents is recommended. So at Bethesda Deaconess Medical Center, we dilute 1-to-1s. We use about 5 mLs of diluted contrast, and then we dilute that up to a total of 10 mLs total. And so we found that is associated with a reduction in risk for back pain, but it may also be associated with decreased risk for reaction. So in general, dilution is recommended, and we can get to that in a second. So if you compare to other tests, this is a really seminal work that's been published by Kim Wei and others, looking at a comparison and contrast to other different types of cardiovascular testing. And what you can see is that the rate of anaphylactoid reaction is 1 in 15,000, but the rate of severe fatal allergic reaction is much rarer. And you compare that to even iodinated contrast, even the low osmolar, more modern iodinated contrast that you have really has a much more frequent rate of life-threatening reactions. And so we always take risks in medicine. We always take risks with the expectation of benefits. And it's a question of balancing that risk benefit and making sure that our risks are minimized and our benefits are maximized. In that setting, contrast is amongst the safest of all contrast in the media. but does have a small risk of serious adverse events. And so it's really important that we all are prepared for this, and we require vigilance and preparedness within labs. We're not used to, as an echo lab, necessarily dealing with acute situations. Our patients, more or less, are stable by the time they're getting their echocardiogram. But that doesn't mean that we can't encounter it. Certainly, this is encountered in radiology laboratories across the board with use of iodinated contrast and other types of contrast media. And certainly, this happens in many other settings in the cath lab, but upstairs or downstairs. So I think it's really important to be prepared as a lab. When we look at across the broad landscape of safety, these are all the safety studies that have been published up to about the time of the presentation here. The biggest one of which is my main seminal study looking at the premier data set, 4.3 million individuals, inpatients who received contrast as an inpatient, did not find an increase in mortality adjusted for risk factors. And in fact, if you adjust for the propensity or likelihood to receive contrast, people who got contrast were actually less likely to die within 24 or 48 hours. Now, I don't necessarily know that that means contrast protects them against mortality or somehow protected in that sense, but certainly it could be, it could help you define the diagnosis better and get an appropriate treatment. But it also certainly indicates that there's not an excess risk of harm in those settings. So I think we can feel pretty good about the use of contrast in these settings, both the inpatient and outpatient setting, stress, rest, or both. And so as a result of this, there's been a chipping away at what still remains, unfortunately, is the black box that's on this. And so back in 2007, the FDA issued a black box warning in response to a cluster of 190 cases of severe cardiopulmonary reactions. Now, not all those reactions were necessarily even related to contrast alone. And so this was a sort of preemptive warning, but has since been sort of modified as some of the data has come back. And so now they've removed, for example, the contraindication of use in pulmonary hypertension and unstable cardiopulmonary disease, and in some cases have removed contraindications to use of shunting in shunt settings. And we know the theoretical risk in that setting, in the setting of an intra-arterial shunt, is that some of these microbubbles might clump together and then therefore obstruct the vascular bed. We know, for example, that the vascular bed is so large that it's very unlikely to happen. Those bubbles break up and are showered into the sort of the tree branches of the vascular bed. So it's unlikely to cause sort of a large embolism of sorts. And that is also the concern in use in pregnancy. There's less data on pregnancy. And in particular, the concern is that there's theoretical risk of sort of placental arterial occlusion. But in reality, many centers that have experiences with use of, including our own in pregnant patients, we have not seen this, at least on a small scale. So what are our recommendations? First things first, train your staff. There are a number of resources out there. Like I said, ICUS website's great. Your clinical application specialists are very knowledgeable. They have tons of resources that they can give you to be able to help train your sonographers. Teach through examples. So what do you do in a given circumstance when a patient presents like this? What will be your next call and response? And have staff repeat back those safety protocols. So make sure that they really completely understand that. So this is our form that we have on the right here. This is what we have in every single site where contrast is used. We have set it up at Beth Israel so that the cardiology consult fellow is paged, and this goes out as a bubble. They carry a bubble pager, and so always there has to be somebody. We know that there's somebody on call for the bubble pager, and as soon as this goes off, it comes up as a stat reaction with the location. They're expected to drop everything and run. This is like a STEMI. We don't want sonographers to suffer in silence. People are not necessarily trained to respond to emergencies. We need that assistance from the first aid team. And so if the patient became unresponsive, we would call code blue. But ultimately, that response mechanism in training and drilling it into the fellows, if you're not going to be there, if you have somebody covering, make sure they're covering the bubble pager and talk to them what their expectations are, has worked out very well. And we have had reactions at our institution because we do use a lot of contrast. And those have gone well, and the patients have been safe, and ultimately a good outcome for everybody involved. Assessing and reassessing competency is important. So not only the first time you teach them, but then every year after that, or at some time interval after that, reassessing to make sure that people have maintained their competency in the evaluation, and then planning for this ahead of time. So Jess and I give talks around the country at various places, and I'm always shocked to see there's lots of places where contrast is used, and there may be not a physician for miles. And what do you do when you're in a circumstance where you have a reaction that happens? The when, the how, and the who is really important. So, for example, when we expanded to a local clinic, we expanded our contrast use to there. But before we even expanded contrast, we said, we want to meet with you. We want to understand how you're going to use it, who's going to be there, who's going to respond to emergencies, and what happens when that person's on vacation. Who's their coverage? What's their coverage system? How would they find out about this? Who's the next step in notification? Having those allergy kits available and keeping them stocked. And don't just leaving them, but keeping them tracked and making sure that they stay up to date is really important. And then when there are issues, tracking them, retaining the vial. You can find a lot number for that, reporting it. The event details to the manufacturer can be very helpful. So it may be, for example, an issue with a particular lot, and then documenting the reaction. What happened? Put it in a note in the chart so people can see it. Add it to some of these allergies so that people are aware of it for future use, and then debrief afterwards with your staff about how do we improve? What went well? What didn't go well? I think this can be somewhat of a traumatic experience, particularly for people who haven't had a reaction beforehand. So I think it's important, particularly as managers, to sit down with the staff and understand what went well, what didn't go well, how are people feeling about this, and how ultimately can we come together as a community to make sure that we're supporting each other throughout this. So the last couple of slides, I do want to talk about some of the newer issues that have come up. And so there's been a sort of focus on PEG, or polyethylene glycol, and I want to sort of unpack this a tiny bit. So PEG is essentially a polyethylene glycol repeat. It's used as an excipient in the production of microbubbles to help stabilize the lipid shell. It is present in thousands and thousands of over-the-counter agents, skin creams, cosmetics, everything across the board. And about 24% of the population has antibodies to PEG, meaning that they have been exposed at some point in time to polyethylene glycol. So why are we only hearing about this now? Well, in 2021, there was, of course, something else going on at the time. I think you may remember, called COVID. And so there was, in response to the COVID vaccination campaign, there were a number of reports of allergies to COVID vaccination. So the FDA looked back on some of the ingredients that were in the COVID vaccine to try to understand what was within the vaccine that could potentially be causing these allergies. And one of the things they found in the vaccine was PEG. And so they issued a safety report on presumed type 1 hypersensitivity reactions due to PEG. But this was based on 11 cases that they had encountered over the course of 10 years. And so it's a small report in general. If you take into account the number of vials and the number of uses of contrast, in fact, the rate of reaction based on this was less than 1 per million. And ultimately, none of these reactions were laboratory confirmed to be due to PEG, and that there's a laboratory test for them. And so there's some skepticism about this. And in addition, all of the safety data that I just showed you from Mike Main and others, really robust safety data, was all published during the time that PEG continued to be used in contrast. And nothing has changed in the concentration or sourcing of PEG since that time. And so I think that this is probably unrelated. That being said, if you do encounter a patient that has had an allergy to PEG, or for example, has had a hypersensitivity to bowel preps, we know that, for example, a lot of bowel preps do have Miralax has polyethylene glycol in it, then that may be something to consider and be aware of. But in general, like I said, it's been used for many, many years. There are two of the agents that do have PEG in them, Lumason and Definity. One, Opticon, does not. It uses an albumin shell. And then, so more recently, there was this article that was just published in JACE, and this was 4 centers that had noticed an increased risk of adverse drug reactions to ultrasound-enhancing agents in the course of the last couple of years. And they speculated that maybe this could be due to the COVID vaccination, they saw an increased rate of use. I reviewed the study in detail. Certainly, there has been clusters of severe reactions, and in general, severe reactions do happen to occur within clusters. And so those who have been a part of those clusters, it can be very jarring experience. But in general, if you look at the denominator and you include all the years of which contrast was used, in fact, actually the rates remain fairly low. And I'll show you some data on that in just a second. We recently, we had ourselves had, in fact, just responded as a sonographer to this case. We did have a case of a severe cardiopulmonary reaction as of recent in response to contrast. And it was a patient who had a recent stent and ultimately was doing well, got a contrast agent, and then ultimately developed flushing hives and then ST elevations on EKG. And they were taken emergently to the cath lab. And here you can see on the left was their coronary angiogram prior to this all happening at the time of their stent placement. And on the right was the time of occurrence. And so there was diffuse spasm of the right coronary artery. And we think this is most consistent with Kunis syndrome, which is an allergic hypersensitivity reaction that can cause either vasospasm of the coronary bed, arrhythmia, or thrombosis. It is extremely rare. It has been described in many other different types of contrast media, but this may be one explanation for example, the rare cases that have been described with very severe reactions. And so we've now submitted this, and this has been accepted for publication and should be published shortly in Circ Imaging. But we feel like this could explain part of the pathophysiologic link, and certainly what some sites are noticing. That being said, I think it's really important. This is I'll be concluding soon, but this is my second to last slide, is to focus on, this is actually the FDA safety data. So this is looking at non-carpal related reactions, and you can see that there has been a gradual increase as we're using contrast a lot more, but that rate of use, the rate of reaction is pretty infrequent. It's in fact less frequent than the non-carpal reactions. And if you include the total overall use, it's about one in less than 1 in 20,000 exposures. And it seemed to have been increasing prior to the onset of the COVID-19 vaccination campaign. So we have as part of ICUS, we have a large multi-center study that's ongoing that we hope to address some contemporary safety of these agents and to address this head on, because ultimately at the end of the day, we do feel that these are safe medications to use in an appropriate setting, but it is important that labs are prepared and in case of an event happening. And I'll leave you with this last statement, which is the harm of not knowing. So the Institute of Medicine came out with a report on improving diagnosis in healthcare, and I'll quote from that report: postmortem examination research spanning decades has shown that diagnostic errors contribute to approximately 10% of all patient death. So there is a harm to not knowing. There's a harm to not knowing the right diagnosis at the right time and acting expediently. And I think it's important that we understand that, yes, there are risks to contrast, but there are risks to everything that we do. There are risks to water if we have too much water intake. So it's very important that we do use it, and we use it and contextualize it in the experience of making sure that we're providing the best quality care to our patients and avoiding harm. So thank you very much, and we'll turn it over to Jess.
Thank you, Jordy. All right, so hi everybody. Thank you so much for joining this afternoon. Again, my name is Jess Stout. I'm the technical director at Beth Israel. I work alongside Jordy here. I am going to go through first kind of our experience as a lab, some of the things that we did to change our workflow and kind of work on some of those barriers that Jordy mentioned in his talk. If we have time, we'll go through some case studies. So we'll kind of go through and just see where we're at from there. My disclosures here. So when we look at our contrast use at Beth Israel, I started here in early 2021, and Jordy joined as the director about a year later or so. But our contrast usage was extremely low because of all the workflow barriers that were present. The biggest one being that sonographers were not able to inject. And so we're very geographically dispersed here, unfortunately. So even at our main campus in Boston, we have 5 different echo labs, and we had one fellow that was responsible for running around to each lab to inject contrast. And we know that as sonographers, we're really busy. We just don't have time to wait sometimes. So that was a huge workflow issue. And so Jordy and I worked to get that changed. I can say for anyone that's trying to do this now at their institution, model it after somewhere else in your institution that's already has a department that has non-nurses injecting. So Jordy mentioned the ophthalmology. For us, another place you can look is radiology. If there's non-nursing injecting contrast, look at MRI, look at nuclear, and just model what they're doing. Don't reinvent the wheel. Here, we had to present first to our clinical policy and bylaws committee. And then that went to P&T, pharmacy and therapeutics. And then finally, we had to send it to the med exec committee. So we had 3 different committees we had to present to in order to get our approval and then get the official sign off, which happened, I believe, late in 2021 that got signed off. The other thing that we looked at was kind of our sonographer take on contrast. I think overall, sonographers were so worried about quantity. They were trying to get their numbers. And for both Jordy and I, we are very much about quality over quantity. So if you do 7 studies a day, I would much rather you do 6 really good studies with contrast than 7 rush studies. And just kind of reworking that culture and that expectation. And then also just holding us all accountable for our work and for our studies. We do monthly meetings with our sonographers. I know that they only come for the lunch, which is fine, but we do review studies. We go over stuff and just try to promote the usage of contrast and where it should be used clinically. And then finally, Jordy touched on this. So the physician champion, Jordy and I are both huge advocates for contrast use. Between the 2 of us, we're probably pretty insufferable, honestly. But all things combined, you can see that our contrast usage has increased and has increased to 18 to 44%. So that disparity is outpatient versus inpatient. And so we know the outpatient barrier is IV. And so we did start recently working on having our sonographers get IV certified. For anyone that's looking to do that in your institution, Jordy talked about trying to get local schools and programs to implement that into their curriculum, but talk to nursing in your institution. See if your sonographers can rotate with the IV therapy team, with the cath lab, with the infusion team. They're usually very, very good at placing IVs. And then implement your own training policy for staff. Again, model it after departments where non-nursing staff is already placing IVs. Look at MRI or nuke med, for instance. So this is kind of our online competency that we have for our IV placement. It's an annual competency that everyone takes, and it's done online. And I'm clicking through it here just to kind of show you what it is. But again, this was made by nursing. I just stole it and put it in for our sonographers. So I'm just using the resources that are already available through our institution. And then we do this competency assessment. Essentially, we have to have 5 IV starts, and we have this online competency assessment that is taken and it's stored within the employee's file, so that Joint Commission comes or any regulatory agency, we have that documentation readily available. And so steps for IV competency: complete the online course, practice on that fake arm that Jordy mentioned, do your 5 IVs. And the most important thing that I can't stress enough is consistent repetition. And so my mistake when I first started implementing the IV training, I would send the sonographers to the cath lab for a couple days. They would observe, they would learn, and then they would be off in the world by themselves. The problem with that is if they have a tough stick, there's nobody there to kind of teach them or show them. And it can be hard to, to do that solo. So I restructured it a little bit recently, and I have one of our more veteran sonographers that's been IV certified for a long time. I have her coming on site for full weeks at a time and just being like the IV resource. So she's there on the first day to teach like a didactic and go over things. And then she's there for the full week so that she's there to help you and just put IVs in back to back, be a resource for you. And so I would just say that if you're considering implementing it, just having a person that can be there to be that consistent resource is really helpful. So that's for the IV starts. The other thing that's really important, for our day-to-day workflow are reactions. And as Jordy said, the likelihood of reactions are rare, but we all should know what a reaction does look like and how to respond to it and have that based in competencies. We know statistically, 1 in 15 to 1 in 20,000 chance of a severe adverse reaction. Here at BI, we do over 20,000 echoes a year. So we know statistically we're going to have reactions. So the question is, how do you manage those effectively? So the most common reactions are things that are really self-resolving and that patients probably wouldn't, maybe not even mention. So things like headache, back pain, nausea, and changes at the injection site. But those kind of anaphylactoid type reactions, these are the ones that we as sonographers, if we're injecting, we need to know what those look like and know and have a policy, to react to those. So, look at your patient, assess your patient before you even start your exam, and then know that these reactions can arise really quite quickly, and that'll be, the redness, the rash, the periorbital swelling, things like that. Listen to your patient. Our patients tell us about all of their ailments. They're certainly going to tell you if they're experiencing something significant. And the story, the Kunis syndrome that Jordy mentioned that we went through recently, that patient was a Mandarin speaking male, and I had an interpreter on the phone the entire time that I was doing the echo. I explained the contrast, and then I was like halfway, almost all the way done, and I said to the interpreter, let me let you go. You're just sitting on the phone. I'll call you if I need you. Did everything, finished the study, did the contrast, and then of course push the contrast, and the patient just looks at me and he goes, hot. And I was like, oh crap, and then immediately you could see the rash and the redness. And so we got the appropriate staff in right away to help handle that. But he knew, and he communicated that to me immediately. And so we were able to address that. So listen to your patient and just understand what these reactions look like. Jordy mentioned dilution. I just want to double up on that. The less of something we're giving, the less likely it is to, cause a reaction. I tend to dilute 1-to-1, and then I only push a little bit. I just assess, make sure everything's good, and then I'll push a little bit more. I don't use much contrast when I'm doing my studies. I don't see the need to use a lot. So in general, I'm diluting and then only using a little bit anyway. So if we do have a reaction, we want to make sure we have clear roles and responsibilities assigned to everybody. Have annual competencies for our sonographers. Our sonographers are not responding to the actual, reaction itself, but they do need to know who to call in what scenario. So we have the annual competencies that are just based on that, and then use those additional resources. Use the CEUS website. They have policies, procedures, things like that, if you need additional help. Jordy showed this, so I'm not going to go over it any farther, but just to say that this was written out at the request of our sonographers. Most of us that work in a hospital setting, we have all those important numbers on our badges. We have all those codes on our badges, and there's a reason for that. We need a place that we can go to, look at them quickly, know the number, because sometimes when we're in an emergency, things just slip our mind. So it's really useful. This is posted in every single one of our rooms where we do contrast. The consult pager, or the bubble pager, is also on every single ultrasound machine for those that are going portable. So this is just posted everywhere, so it's very clear steps to take, who to call if there is any sort of reaction. And this is really wordy. This is really something that's more for our fellows that respond. This is a guidance document. If the patient's presenting with this, then this is the appropriate treatment. If it's a mild versus moderate versus severe reaction. Every med that's on this management document is also in that allergy kit that Jordy had shared before. So it's just here, obviously, clinically, when you actually have a patient presenting, it's not always going to be so cut and dry, but this is at least here as a guidance document for those fellows that are responding to events. Again, we stole this from radiology. Radiology was always already using this because they have a much higher incidence of reactions to their contrast. So they've already done all this and it's working for them. So we really just took it, we tweaked a few things that worked for us, and this is what we use now. And our allergy kit, the only thing I want to add about this is for anyone wondering about storage, we did have Joint Commission come through while we had these, and they completely checked off the way we were storing everything. They were totally fine with it. We do keep them locked with like one of the code cart locks that has the numbers on it. So we do a weekly check and sign off that the lock hasn't been changed or tampered. And then we do a monthly check and a check and change of any expired items, and then document that. And then all those documents are saved for reference later if needed by anybody. So they signed off on that. We also keep it in a locked cabinet because there is meds in there. So it needs to be in a locked area. And then just after an event, you know, they happen. And the most important thing we can do is just meet with our staff and see how things went. The best lessons learned are when we're actually, you know, going through these events. We've made quite a few policy changes based on events that we've had over the past few years. And so the first thing I always ask our sonographers, if we do have any adverse events, is, you know, did you feel supported? Did you have someone there immediately? Things like that. And some of these things like the allergy kits, those all came up as suggestions from our sonographers and also our physicians that responded. So sometimes that's the best way to learn is kind of by doing and by seeing where your deficiencies are. Obviously, everyone's going to look different. We have fellows that respond. Some people are going to have nurses. Some people, you know, so you just have to do what's best for your institution. Our outpatient sites, I don't allow any contrast studies to be done after 4 o'clock because it's just a ghost town after that, and I don't trust that there would be an appropriate response. So just do whatever you have to do with your policies that works with your institution and your guidelines. And just some special populations. A lot of people ask about pregnancy, and you know, pregnancy hasn't been studied. It's, you know, in clinical trials, and there's a reason for that, because no pregnant woman is gonna, you know, step up and say, yes, please, you know, give me this contrast and see what happens. And so again, this will differ by institution. The theoretical concern is kind of what Jordy had covered earlier, is that the contrast agent will clump together and can potentially cause that placental obstruction. But the vascular bed is so large that that's really just not feasible. So it is a case-by-case basis in our lab. Ultimately, it's reviewed by the attending, and if it's you know, missing a diagnosis and we have to use contrast, then we use the contrast. But it is determined on a case-by-case basis. ECMO, you do have the bubble alarms on potential, or potential for the bubble alarms for the ECMO machines. Essentially, they're looking for air, and there is a chance that the pump cuts off if they detect air. I've never had that happen, but in theory, it could. So we always page our heart failure fellow, who coordinates with us if we do need to use contrast on one of our ECMO patients, just so we have support there should an alarm go off. Because obviously, if I'm there alone, I would have no idea what to do if the ECMO stopped going. So those are a couple of special cases there. And now some case studies. If we have, I think we have a little bit of time. Jordy, are you okay going through a few case studies, or what do you think?
Well, I think there's some. Thank you, first of all. That was a great talk. I think there's some questions.
Okay.
So we went a little bit long, and maybe some of the cases we can save for a different time, and then we can address some of the questions that have come up. So, I'll sort of read out and then can sort of address some of the things. One of the questions that was brought up was, if there's a reaction, do you call a general rapid response? And I think it's a really good question. We do not. I mean, we don't just pull out a code pager unless the patient is truly coding. And we find that the general rapid response team, maybe internal medicine physicians or ICU physicians, et cetera, may not be as familiar with a contrast reaction, what happens within a contrast reaction, the nuts and bolts of it, the acuity of the treatment, et cetera. So we actually go directly to use our stat bubble pager. That pages out to the cardiology fellow and who's trained in how to respond, and we found that to be work pretty well.
Jordy, if I could expand on that just a little bit, I'd also suggest too, if you have like a big ICU presence and you're in the ICUs a lot, using a lot of contrast, like talk to the nurses there, let them know what you're using, why, have your administration talk to nurse managers, because it's really helpful if they understand what we're using, and then ultimately what could happen, and why we're reaching out to our fellows, things like that. So.
Yeah, I think that's great. And in particular, also, I mean, you raised the point about dilution earlier, and I think this is what brought up in the chat and the questions as well. And if you have somebody who's not familiar with how to inject contrast, sometimes what you'll find is they get the contrast and they just give a giant bolus. And we think, at least, that the rate of reactions is related to the peak concentration of it. And we don't have definitive data on that yet, but certainly there are some signals in the data that there may be sort of lower rates of reactions amongst those who dilute and sites that dilute. And so that does suggest that sort of minimizing the amount of contrast that you give up front, but also sort of diluting to try to minimize that peak dose may ultimately have a benefit, not just for back pain, but also in terms of reducing the risk of this. And so this is always something that if you're not the one pushing contrast, you are often the one who's most knowledgeable about that contrast. And so be sure that if you're working with somebody else, that you can make them aware of what to look out for and how to give it, because it really is a slow injection. We give a flush of saline over 20-30 seconds at most. And the worst comes to worst, you give too little and you give more. We will often give a half a cc or 1 cc to start of a diluted solution, a 1-to-1 dilution, and that's enough in many cases to really get a good effect. So
yeah, unless I have like a huge blown out apex, like I'll start with a half cc. And obviously, if I have a big aneurysm, you have to push a little bit more faster, but I usually start with a half cc.
And I would tell you, what's on the label is not necessarily what we recommend here. CEUS has this on the website. There's a great list of protocols you can go through and recommended dilutions based on the agents that you use. But what's on the label is what was studied. And so the clinical application specialists, they're phenomenal. Their hands are a little tied based on what's on the label. And so they can't tell you to go use a diluted agent. They can maybe strongly suggest, but they can't tell you that. And so we're telling you that as a result. And so definitely makes sense to use a dilution. And if you're able to use an infusion, that's even better. Infusions are a little different, that you can sort of titrate to the level, to the appearance of the LV. So if it looks sort of under-opathified, you can give more, increase the rate of infusion. If it's over-opacified, you can decrease it. And and that allows you to sort of titrate it over time. It means that you don't have this sort of large bolus and then washout experience. And so it's quite nice. The one thing I would say is if you do use an infusion, the bubbles settle. They actually come out of solution, they settle. So just make sure that if you're sitting in it for a long period of time, that you are mechanically agitating your syringe. There was a question about is there available recommended list of medications and items needed to create an effective tackle box kit, an allergy tackle box kit? And that's a very, very good question. We can try to share our allergy tackle box kit information with the powers that be. I want to say that maybe on the CEUS website. I don't know to be completely frank. Because I think we have shared it in the past, but if not, then we'll try to see if we can get it onto the CEUS website so that people will have that available to them. But they're it's garden variety routine medications that you use in the setting: famotidine, EpiPen, saline, IV start kit.
I would say, if anything, to start, have an EpiPen and have, you know, some Benadryl on hand. I mean, those are the two very most important things. I can't stress enough how effective an EpiPen is to have, and how much of a peace of mind it is just to have it right there in case there is a reaction.
Yeah, and it's great. And there was a question about whether or not we have those available on the floor. We don't necessarily have them available on the floor because we don't necessarily use contrast as readily on some floors than others. And so we don't have, I mean, certainly things like cardiology floors where we would expect that we would use contrast a lot. It makes sense, I think, to have those allergy tackle box kits. But and within the Echo Lab, it makes sense to have. But again, it's going to depend on your institution and your setup, and in terms of where do you use contrast the most, and where you use contrast the most, it probably makes sense to have those kits available.
And I did talk when Joint Commission was here last. I did talk to them about the feasibility of having a smaller kit that goes on the ultrasound machine, because we are a very portable, heavy lab here at Beth Israel, unfortunately. And they were fine with it. They said as long as it's you know, locked with a tag, again with a number on it that can be recorded, so you see if that's been broken, and as long as it's locked up you know, at the end of use somewhere, then that's totally fine. So from a regulatory perspective, that's fine to do.
And do you monitor patients afterwards? Was one of the questions. Not really. You know, typically speaking, these reactions happen immediately or almost immediately. So if you're going to see it, you're really going to see it within the first couple minutes afterwards. So what I do think it's helpful to, as just mentioned, turn on the light. You know, if something's happening and the patient says they feel funny, turn on the light and look at the patient. Make sure there's no rash. I mean, we often are sitting there in the dark, and it's hard to assess a patient in the dark, but it really is something about being able to assess the patient up front, and you have all the skill sets to be able to do that. It's great if you can call somebody, as long as that person knows that they've got to come immediately. But you can do a lot of the workup while you're waiting for that person to come. You know, go look at the person's chest, see if they're hives, check the blood pressure, take their heart rate, do the basic set of vitals so that you can be aware of what's going on there. Have you noticed more reactions with one agent in particular? It's a bit of a loaded question. What I would say is no. We in particular use one agent, use Lumison, but we've used all three agents in the past, with Optison and Definity, and I can tell you that we have not experienced a particular sort of clustering of reactions in one versus the other. And I can tell you that the Kunis syndrome that I described earlier has been described with other agents, with multiple agents within the context of injection. So I think I don't have, put it this way, I don't have the data to show you that one is different than another. I don't have data on that, but what I would say is that it is it's certainly a sort of more broad concern, and we should all be prepared regardless of what agent you use. Are the rashes typically located to a specific area? It's a good question. Yes, typically they're truncal. They start truncal and they move centrifugally. So they start on your chest, your back. Those are the places where people feel it the most. They spread up to the neck, to the arms. And so it helps to make sure you're looking at that patient's chest. They're wearing a Johnny, pulling it down and taking it in the chest. who administers the EpiPen and Benadryl? Beth, do you want to take this one?
Our fellows do. The fellows that Responding administers. I don't know of any institution that has sonographers doing that. It's a whole nother can of worms. For me, I don't think our sonographers would be comfortable doing that, so it's not even somewhere I want to go. And ultimately, for me, it's the sonographer's comfort in what they're doing. So I think our response is fast enough where we can rely on the people that are responding to be there fast enough to be able to administer those drugs quickly so they can be effective. And as long as that's still the case, I don't see a need to have sonographers be doing that.
Do you have any concerns about contrast in pregnant women or breastfeeding women? So good question. This is something I think both Jess and I touched on a little bit, at least from the pregnancy standpoint. The concern there is more theoretical than not, except that the contrast can sort of clump together and obstruct the placental vascular bed. In experience, we do have experience with that. We always have a fellow present when we do give it to a pregnant woman, just because it is not something that is as studied. But we haven't had any ill effects towards that, and we certainly do use it in pregnant women as well. And in terms of the breastfeeding aspect of it, it's a good question. I don't know, to my knowledge, that there's any risk to breastfeeding whatsoever. These agents are basically turned into gas and just breathe them out, and they're either in solution, absorbed or breathed out within a very sort of short amount of time. And so after injection, so really to then sort of get into the breast milk and affect the breast milk at high enough concentration where it would make a difference would be, I think, extremely unlikely. Somebody said being prepared is key. The FAERS website provides great data with good reactions to each agent. That's right. So that what I showed earlier in the slide on the 1 in 20,000 non-carpal risk. That was from the FAERS website. So for those who are not familiar, FDA tracks all safety events. In fact, each company, each vendor that produces bubbles is required in pharmacovigilance. They have a pharmacovigilance section that reviews and reports any serious adverse reactions. So all that is publicly available data, and it's available on the FDA website. And so this is provided that it was reported, but it is a good resource. Would you be willing to share the guidelines for management? Absolutely. Happy to share. We're happy to share whatever kind of materials that people want to form. Other questions that people have? Well, I think we're almost at time, so that is a sort of a nice timing. We'll have to do the cases at a different time or a different webinar. But thank you, everybody, for spending your afternoon with us, or morning, or evening, or whatever time it is in your part of the world. We really appreciate this. We really hope that you learn a lot from this experience, and that you take some of these lessons back to your own institutions, and we try to bring the best quality of care to our patients as possible. Thank you so much.